Good evening, everyone, and welcome to a new session of our course. Today's session, we are going to discuss the glaucoma. And as you know, the glaucoma is an important section in not only the ICO, but every exam, FRCS2, FRCF, whatever exam that you are applying for, you will find a ample number of glaucoma questions. So this lecture will be in a systematic way as usual. So we are going first to cover some fundamental knowledge about the glaucoma because they are sometimes asked in the clinical exams. We will not dive into too much details, but we will just give the information which are necessary for the exams. Then we will go through the clinical evaluation and regarding the examinations and investigations of a case of glaucoma. And then we will go through the topics of glaucoma, starting by open angle glaucoma, the primary and secondary one, then the closed angle glaucoma, the primary and secondary glaucomas, and the congenital glaucomas, the primary and secondary. So this will be mainly for this lecture, and for the next lecture, it will be the medical management of glaucoma, including the medical treatment and surgical treatment, and also the laser treatment. So let me start first by some fundamental knowledge about the glaucoma. So beginning back to the basics, if you remember the anatomy of the ciliary body, so the ciliary body is a ring of tissue about 6 millimeter wide, which forms the middle part of the uveal tract. So anteriorly will be the iris and posteriorly will be the choroid. It will extend from the scleral spur, which will be an important anatomical landmark of the angle of the anterior chamber, to the ora serrata. So the ciliary body extends from the scleral spur to the ora serrata. If you think of the ciliary body, you can consider it like two different kinds of tissues, that are termed the ciliary body. One of them is called the ciliary muscle, and the ciliary muscle is what is responsible for accommodation. So by contraction of ciliary muscle, this will result in accommodation. This is one function, and the other function that it will help in aqueous drainage. The other part, which is called the ciliary process, is responsible for aqueous formation. So here is the ciliary process, and posterior to the ciliary process will be the ciliary muscle, or within the ciliary process there will be ciliary muscle. The more internal part will be the ciliary process, and the more exterior part will be the ciliary muscle. So starting by the ciliary muscle consists of three parts. The first one is called the longitudinal fibers or the meridional fibers. So these are the longitudinal fibers, and the radial fibers or oblique fibers, which will connect between the longitudinal fibers and the circular fibers or the sphincteric fibers. So what is the function of each one of those parts? So the longitudinal fibers will be responsible for pulling on the scleral spur. They have attachment to the scleral spur. So what will be the net result? That they will open the trabecular meshwork. So they will help in aqueous drainage. So if you check here, you will find that these longitudinal fibers will be attached to scleral spur, which is present here. And so contraction of the longitudinal fibers of the ciliary body will result in pulling on this scleral spur, so it will open the trabecular meshwork. So this will help in aqueous drainage and aqueous outflow. That's why there is a certain category of anti-glaucomatous medications. It is called the miotics. And those miotics will cause contraction of the ciliary muscle, and they will help in drainage of the aqueous. Okay. The radial fibers is just connecting between the circular and longitudinal in order to prevent the tear of muscle during contraction. And the circular fibers is what will be responsible for accommodation. So when it contracts, it will result in decreasing the ciliary body ring, leading to slackening or laxity of the zonules, leading to that big increasing convexity of the lens, increasing the dioptric power of the lens, and accommodation. So this is not our concern here, but our concern is mainly on the longitudinal fibers. So when the MCQs asks you about what kind of muscle fibers in the ciliary muscle, which will be responsible for increasing aqueous drainage, this will be the longitudinal fibers. Back to the anatomy of the ciliary body. So when we are dividing it into anatomical regions, there will be the pars plana, the posterior 4 millimeters. It's called the pars plana or orbicular ciliaris, and the anterior 2 millimeters. It is called the pars plicata or the corona ciliaris. So the pars plicata is formed of 60 to 70 of ciliary process. If we have a higher magnification of the ciliary process, we will find that it has an inner non-pigmented epithelium and outer pigmented epithelium. So, and in the ciliary body stroma, there will be a vascular core. It will be formed of arterioles and venules. So these will be are the vessels or the blood vessels that will be responsible for aqueous formation. So the aqueous formation is starting in the ciliary process, and it is under the control of certain types of receptors. These are the alpha-2 receptors and the beta-2 receptors, meaning that the inhibition of the alpha-2 receptors will lead to aqueous formation. Also, the stimulation of the beta-2 receptors will lead to aqueous formation. And this is why, in order to decrease aqueous production, we need to act on these receptors. So we need to either stimulate the alpha-2 receptors by the alpha-2 agonists, or to inhibit the beta receptors by the beta blockers. So in this case, or in this category of drugs, they will act on the aqueous formation rather than the aqueous drainage as the miotics. So in order, again, to decrease aqueous formation, we just need to stimulate the alpha-2 receptors by the alpha-2 agonists, or inhibit the beta receptors by the beta blockers. Speaking about the aqueous formation, the aqueous formation is formed by different mechanisms. So starting by the diffusion. So diffusion is a simple physical process in which the solutes move by concentration gradient. So if we have two solutions and each solution contains solutes, these solutes, they can cross across the semi-permeable membrane till the other side. So this is called the diffusion. They will just move by concentration gradient from the part of higher concentration to the part of lower concentration. The other mechanism responsible for aqueous formation, it will be the ultrafiltration. And in the ultrafiltration, the solutes are moving by the pressure gradient. So if there is pressure, like the oncotic pressure of the plasma proteins, it will help in moving the solutes from the plasma into the within the blood vessels in the ciliary process. It will move by the oncotic pressure of the plasma proteins to be filtrated outside these blood vessels. The other and the most important mechanism which is responsible for the aqueous humor formation, it will be the active transport. So in the active transport, the solutes move against concentration gradient. So you can find at the right side here, the solutes are much more than the left side. However, the solutes will move from the left to the right. This is because this mechanism is energy dependent. So and this will be the main mechanism responsible for aqueous formation. Speaking about the aqueous formation and the solutes, and what are the aqueous humor contents. So what are the solutes that are making the aqueous humor? So the aqueous humor is rich in water, lactate, and pyruvate, which are the metabolites of metabolic process, which will result in energy production. Ascorbic acid, which is an antioxidant, and regarding the electrolytes, it will be also rich in chloride and hydrogen. There will be low protein content in the aqueous humor thanks to the blood aqueous barrier. There is also low glucose content because it is rapidly consumed for the metabolic processes, and it will also have low bicarbonate and low phosphate. Then we'll speak about the aqueous humor outflow. So the aqueous has two main outflows. Once it is secreted or produced by the ciliary process, it will pass into the posterior chamber. Then it will move through the pupil, and then it will get or will reach the anterior chamber to be excreted. So how it is excreted, or how does it is the anterior chamber will get rid of this aqueous? It will be through two main pathways. The main pathway is called the conventional pathway, and this pathway is responsible for a drainage of around 80 to 90% of the aqueous humor. In this pathway, most of the aqueous will pass through the trabecular meshwork, then into the canal of Schlemm to be drained by the collector channels and aqueous vein into episcleral veins into the subscleral space. So this mechanism is controlled by the trabecular meshwork. If the trabecular meshwork is healthy and functioning normal, there is no obstruction to the trabecular meshwork, this will result in normal and smooth outflow of the aqueous. If there is any abnormality in the trabecular meshwork, as the most of the diseases that we are going to discuss today, this will result in the increasing the intraocular pressure. However, there is another mechanism which is responsible for drainage of about 10 to 20% of aqueous humor, which is called the uveoscleral pathway. In the uveoscleral pathway, the aqueous will be absorbed through the root of the iris into the ciliary body, and from that into the supraciliary and the suprachoroidal space. So, and then from that, it will be drained by the venous circulation in the ciliary body and in the choroid and sclera. So again, in the uveoscleral pathway, the aqueous will pass through the root of the iris to the ciliary body here and to the suprachoroidal space. How? Through the venous circulation in the ciliary body and in the choroid and in the sclera. And there are some drugs which will help in increasing in the conventional pathway, as we just mentioned, like the myotics. And there are also other drugs which will improve the uveoscleral pathway, such as the prostaglandins analog. So it is very common questions in the exam to ask you what will be the mechanism of action of the anti-glucomatous medication. So I guess that you now know the commonest mechanisms of the commonest drugs. As we are talking about the trabecular meshwork, the trabecular meshwork itself doesn't have different levels of resistance. So the trabecular meshwork is consisting of 3 layers. From inner to outer, it will be the uveal meshwork, then followed by the corneoscleral meshwork, then followed by the juxtacanalicular meshwork, which will be closer, or it will be in conjunction with the inner wall of the canal of Schlemm. So the aqueous humor will pass through all these kinds of meshwork until it reaches the canal of Schlemm. And not all of them will offer the same resistance to the aqueous outflow, being the juxtacanalicular will have the smallest pores within this meshwork, which will offer the highest resistance to the aqueous outflow. So this also was asked before in the clinical exams. So this is the uveal meshwork, the corneoscleral meshwork, and finally the juxtacanalicular meshwork. And the juxtacanalicular will offer the highest resistance. And as the aqueous is filtrated by the canal of Schlemm, it will pass through the deep scleral plexus, then the intrascleral plexus, then the aqueous veins and episcleral veins. So if there is any problem like increasing the high venous pressure, like as we mentioned before in the pathology, as we mentioned in the Sturge-Weber syndrome, where there is choroidal hemangioma, or if there is a carotid cavernous fistula where there is high pressure in the cavernous sinus, these veins will face high resistance. So that's why there will be high episcleral venous pressure, and that's why those patients will be at high risk of developing glaucoma, because the aqueous will not be able to pass through this pathway. Okay, so this is the canal of Schlemm, and these are the pathways or the venous plexuses responsible for drainage of the aqueous. Another important concept also is the Goldman equation. So in the Goldman equation, it is a physical equation to measure the amount of intraocular pressure. So the intraocular pressure within the eye is controlled by certain factors. We just mentioned almost all of them. So the pressure inside the eye in millimeter mercury will be equal to the rate of aqueous formation, which will be termed as F, divided by C, which is the facility to the aqueous outflow, plus P, which is the episcleral venous pressure. So again, the pressure inside the eye will be the rate of aqueous formation by the ciliary process, divided by the rate of aqueous outflow from the trabecular meshwork and so through the conventional and the uveoscleral pathway, plus the episcleral venous pressure. That's why, so these are the three factors that will determine the intraocular pressure. So if the exam asks you, what will be the most important factor that will control the intraocular pressure, whether it is the aqueous formation or the resistance to outflow or the episcleral venous pressure, it will be the resistance to the aqueous outflow. So you can see that the resistance in the aqueous outflow, it will be it will be here that the rate of the pressure will be equal the aqueous formation divided on the facility of the aqueous outflow. That's why the facility of the aqueous outflow will carry like a high significance to change the equation. Because of this, because of that, it will be present here in the dominator part. While you can see the episcleral venous pressure, it is just preceded by a plus sign. So like if there is increasing 1 in the episcleral venous pressure, it will result in increasing 1 millimeter mercury by simple math. So it will be not that important factor that will control the intraocular pressure. So here the facility to the aqueous outflow will be much more important. Okay, so let's now move to the other important thing, which is the factors which are controlling the intraocular pressure. This is also very common question in the clinical or even in the basic. So we have some factors that will increase the intraocular pressure, causing high intraocular pressure, and other factors will cause low intraocular pressure. So as I am always telling that the glaucoma is a disease of risk factors. So one of the mysterious things about this disease that since that we have all different bodies, we have different age, different genetical basis, we have different sexes and different races. That's why our body respond differently. So the intraocular pressure will behave differently in different bodies. And this behavior will depend on certain risk factors. So again, glaucoma is a disease of risk factors. So let's see what are the risk factors which carry more risk of high intraocular pressure. Like for example, the genetics. There are some people who are more prone to develop higher intraocular pressure because of genetical basis. That's why the family history is very important in glaucoma, as I'm going to show you right now. That those patients who are relatives or have their fathers or mothers, they have glaucoma, they are at huge risk of developing glaucoma, as well as their siblings. And then another factor is the age. It was found that the intraocular pressure is equal in like between 20 to 40 years of age, but as the age is getting older, as persons or individuals are getting older, they're becoming more at risk to develop glaucoma. And this may be attributed to that maybe the trabecular meshwork is becoming full of debris. These debris are accumulating within the trabecular meshwork all over these years, causing blocking of this trabecular meshwork and rising the intraocular pressure. This could be a theory. But anyway, that the higher the risk is more within the higher age or increasing the age. I'm speaking specifically about the primary glaucomas. So the primary angle closure, primary open angle are at more of higher age group. Regarding the sex, it was found that the IOP is equal between sexes, between 20 to 40 years of age. However, as a person is getting older, it is becoming more increase in women. So women will show higher intraocular pressure than men above 40 years of age. The race, Well, the race is just more high in black. So the intraocular pressure is more higher in black. And as I always say that it will be, you can think of it like the hypertension, the essential hypertension. The essential hypertension is dramatically more increasing in blacks, like in African American or so. And their body behave differently. Like if you just eat 1 teaspoon of the of normal salt, of normal food salt, your body will behave in a way which is totally different than the African American when they eat the same teaspoonful of salt, of the food salt. So they will tend to show higher rise of their blood pressure. The same way here for the Africans or the African Americans or the black, they will show different responses to the intraocular pressure. They will show more tendency for glaucoma progression than the normal individuals. So this is a countable risk factor. The refractive error is also very important. Like it was found that there is a positive correlation between the intraocular pressure and the axial length. So if there is there will be higher intraocular pressure with longer axial length in patients with primary open angle glaucoma, as well as those who have short axial length with highly hypermetrope. It was found to be correlated to the angle closure glaucoma due to angle crowding and shortening of the eye. Diurnal variation also has a factor to affect the intraocular pressure. It was found that the intraocular pressure tends to be higher in the morning, while it tends to be lower in the afternoon. So, and that's why it is also it is always said that the IOP will show cyclic fluctuations throughout the day. We don't have a fixed intraocular pressure throughout the day. It will tend to go up and down. So is this like, what will be the range? It will range around 3 to 6 millimeter mercury between day and night. And if this variation is high, if there is greater fluctuation, like if it is more than 10 millimeter mercury between day and night, then this will be suggestive of glaucoma. So it is very important to, when we are judging a patient as glaucomatous, to measure the intraocular pressure between day and night to check for this diurnal variation. Hypertension also have been associated with higher intraocular pressure. So there will be like a positive correlation between higher blood pressure and higher intraocular pressure. Hyperthermia as well will cause higher, can be associated with higher intraocular pressure. Pregnancy, caffeine and tobacco. And ironically, there are some factors which will cause low intraocular pressure, like marijuana and alcohol. So you see that the bad stuff like marijuana and alcohol will be associated with low intraocular pressure. So there are certain trials on the way throughout the world about giving marijuana drops to anti-glaucomatous as an anti-glaucomatous for patients, and it showed good response, by the way. And even recently, I read that they also offer marijuana for COVID-19, and it showed that it will give like some sort of resistance for the virus, for the COVID-19 entry within the cells. So it will also be protective against the COVID-19. So maybe the next era we will see that the marijuana will be more legal and be more widely distributed as a healthy thing rather than a harmful thing. We will see that, and let's now talk about the measurement of the intraocular pressure. There are many ways to measure the intraocular pressure. Previously, or I will not say historically because it is still used in some places, there is a device called the Schiot's tonometer. The Schiot's tonometer, it will be based on the indentation. Like we put a certain weight here in this device, and then put this device on the cornea. This will result in indentation of the cornea. And by this and this weight together with this scale, it will point to a number. This number is not the intraocular pressure, but after you put this number into a table, this number will correlate to or will point to a specific intraocular pressure. So what is the, we need for all devices that are used for intraocular pressure measurements to know what are their limitations and why they are not useful for every case, because every one or every method has its own drawbacks. The drawback about the Schott tonometer is that it is affected by the corneal rigidity. So when we put this device on the cornea, and it will cause displacement of the corneal tissue, if the cornea is very rigid or very tough, or the reverse, or the very fragile or very soft, this will result in changes or fallacies in the measurement of the intraocular pressure. So again, the Schott tonometer will be affected by the rigidity of the cornea. The gold standard for measurement of intraocular pressure, and it is also named the gold, so it is called the Goldmann tonometer. The Goldmann tonometer is a slit lamp attachment which will be put on the slit lamp and act by the principle of applanation. So what is the principle of applanation, or what's called Imbert fix principle? It means that in order to, it is a simple physical law that in order to applanate a sphere, in order to applanate the sphere, if we are applanating a specific area within the sphere, the force applied from outside will equal to the pressure inside. Regarding the, so that if we wanted to know the pressure inside the sphere, we know we need to have either a fixed force or a fixed space or a fixed area. It was found in the eye, it will be much easier to have a fixed area than to have a fixed force. So we have a fixed area of applanation, which is equal to 3.06 millimeters through the cornea. And we change the force through this knob in order to change the number. And this number will be significant, or will be pointing to the pressure inside the eye. Okay, so this called the Imbert fix principle, that we are flattening or applanating a specific sphere of the cornea, which is around 3.06 millimeter, in order to know the intraocular pressure. So it will be like an indirect way to know the intraocular pressure. So this applanation tonometer, it is calibrated on central corneal thickness of 445 microns, or you can say almost 450 microns. Sorry, it is 500, not 400. So it is 545 micron. And this was like the average population, so around 542 micron. Okay, so that's why if the patient has like a thick cornea or a thin cornea, we need to make some certain adjustment to the intraocular pressure measurements. Like if for every 10 microns of increasing or decreasing in the thickness of the cornea, this will result in increase of or decrease of the intraocular pressure by 1 millimeter mercury. So it will be like around 10 to 15 microns. It will result in change of 1 millimeter mercury. So this should be put into consideration when we are diagnosing a patient as glaucoma. So that's why there are certain limitations. So speaking about that, this device is based on the corneal thickness, or it is calibrated on certain corneal thickness. This will make this device also vulnerable to limitations and fallacies. And this is also very, very important topic in the exams. Like this measurements could be a false low, or there is an underestimation and the intraocular pressure should be higher, or it could be false high or overestimation. So how, first of all, how do we measure these Myers? So when we find these Myers of the applanation tonometer is thin like that and away from each other, this means that it will be, we are still too low pressure for the correct position. And if the Myers are thick, or their inner parts or inner semicircles are going inside each other like that. So this means that we are giving too much pressure over the applanation tonometer. So again, back to the false low or underestimation. When does we have an underestimation? Like if there is a thin cornea, because in thin cornea, you will, by simple or by the slightest measurements or by slightest increase in the force of this applanation, it will result in applanation. So like if the patient, for example, has a pressure of 30 millimeter mercury, and you just, when the pressure, or when you find or when you do the applanation, you find that the Meyers or the semicircles become normal at 20 millimeter mercury, and you think that this 20 millimeter mercury is the normal measurements. No, it is 30. But because that the cornea is very thin, so the slightest, only the 20 millimeter mercury was enough to applanate the cornea. Okay, so this is a false low because of thin cornea, which happens frequently after you are measuring the intraocular pressure after refractive procedures such as LASIK. So LASIK is causing thinning of the cornea. That's why you should pay attention to this thinning in those patients, and that's why also you should consider doing LASIK for glaucomatous patients, that this will pose certain challenge in measurement of the intraocular pressure after the surgery. Like if the patient is glaucomatous with 30 millimeter mercury, it will tell you like it is 20 millimeter mercury. So this will underestimate the pressure. Also, if there is thin Meyers, as we just mentioned, if there is thin Meyers like that, this will be an indicative of a false low or underestimation. Also, if there is corneal edema, but you may be surprised why the corneal edema cause false low or underestimation. It should be that the corneal edema is causing thickening of the cornea. So thickening of the cornea should do overestimation. Well, because of that, the corneal edema will make the cornea thicker, but it is more soft. It is softening of the cornea and becoming like sponge, so that a slightest pressure on this cornea will result in high intraocular pressure. So or the slightest pressure on this cornea will result in measurement of underestimated value of the pressure inside the eye. So corneal edema is causing false low or underestimation. If you just reverse these, you will find the false high or the overestimation. Like thick cornea, in the thick cornea, you will have to exert too much pressure in order to reach the correct intraocular pressure. So this will be not the actual intraocular pressure, it will be just an overestimated value. So thick cornea is a cause of false high or overestimation. Also, the thick Meyers, if you have this view during measurement with these thick Meyers and excessive fluorescein, this means that you are way over the normal measurement. If there is a corneal scar, again, you may be surprised why a corneal scar causing false high or overestimation. This is because that the corneal scar is a tough tissue. The corneal scar is causing thinning of the cornea, so you are surprised why. The cornea is thin, so it should be an underestimation, because the corneal scar is causing it is not a normal cornea, it is a tough fibrous cornea. That's why you need to exert a higher pressure over it in order to reach the intraocular pressure measurement. Okay, so I think that this answered your question, Dr. Atif. So the corneal scar, it will be the exact reverse of the corneal edema. So it is not only about the thickness, but also the internal structure of the corneal tissue. Another method another one of the limitations of the applanation tonometer is that it is an attachment to the slit lamp. So we need that the patient will be able to sit on the slit lamp. So what will happen if a patient is bedridden, or he's a child, or a baby, or examination under general anesthesia? Then we have another method for those cases. It will be called the Perkins tonometer. This is a portable version of the Goldmann applanation tonometer, in which it has a forehead rest that will rest on the patient's forehead, and this will be the same cone which will be applied on the patient's eye. It will be the same measurement. Okay, so it will be paralleled in accuracy to the Goldman applanation tonometer. A less accurate device, but it will be more easy to use and has more flexibility, will be the TonoPen. Like, it is an electronic device which is called electronic indentation or applanation tonometry. So by this device, we are doing applanation over the cornea by just tapping over the cornea, like 10 or 15 taps, and it will record the intraocular pressure. So the advantage is that it doesn't require experience. It will be helpful for patients with corneal scars or edema. However, but the problem is that it is maybe one of the least accurate. So we just use it for cases where we are unable to measure the intraocular pressure due to edema or scars, or if the patient is uncooperative. Another way is called the pneumatotonometry, or the non-contact, or the air puff tonometer. This is a device which looks like more or less like the autoref, and it doesn't require anesthesia. That's why this is because there is no contact to the patient's eye, and it will measure the time. This will depend on an air jet which will be forced toward the patient's eye, and then this device will measure the time of this air force that will be necessary for the air force to flatten an area of the cornea. So the patient will feel like if there is a puff of air which will be projected toward his eyes. What is the advantage? No anesthesia, no risk of transmission of diseases such as HIV or adenovirus or any virus which is transmitted through the body fluids. And it will be good for screening. So for like if you want to screen large numbers for patients who for the higher intraocular pressure, it will be helpful for measurements of large number of patients. However, the drawback or the limitation of this device that it will tend to show overestimation of the intraocular pressure. Okay, so this was also asked before in the exams. Finally, the dynamic contour tonometry. Dynamic contour tonometry is a non-applanating method. It will measure the intraocular pressure not by applanation, not by flattening an area of the cornea, just by pressure sensor. So this device has a pressure sensor, which is when placed over the eye, it will detect the pressure inside the eye. So since it is not dependent on the applanation principle, so there will be less effect of the central corneal thickness and the corneal biomechanics. So there will be like this device is not affected by it is not dependent on flattening of the cornea. So if the cornea is thick or thin, doesn't make a difference. That's why it will not be a problem if a patient had LASIK and to do this device if the patient has thin cornea. However, it will be affected by corneal curvature. So the limitation of this device that it will not be very helpful for patients with keratoconus. They will have very steep cornea. It will be affected. So it is the measurement in this device will be affected in patients with keratoconus. Okay, easy. This is the introduction. So we got an overview about different the anatomy and physiology of the aqueous humor formation, the measurement of the intraocular pressure, and the risk factors for intraocular pressure. So if you have any questions, please let me know.